We know that these neurodegenerative disorders or diseases are actually protein diseases, protein aggregates in those diseases. And we have one in Huntington disease, we have one in Parkinson disease, and in Alzheimer's we have beta amyloid that aggregates. Now we have to approach it in a different way. We have seen so many negative trials giving antibodies to amyloid. I think we have to go understand the basic mechanism much more. And these are mainly, I would say, intracellular, intraneuronal mechanisms where the molecules, the proteins aggregates to larger, you could call it peptides. And our approach then is to really study the chaperones that react with the co-chaperones and help to in-transport toxic things into the mitochondria. And that's why the synaptic death occurs, why the synapses they need energy, and the mitochondria is the energy producing source for those. So the therapeutic approach we have is to really interact on the protein-protein interaction and to stop that and to stop the in-transport of toxic things into the subcellular compartments like the mitochondria. So now we have identified more than 100 molecules that we are testing, first in cell lines, then we move over to Alzheimer animal models, the fruit flies, the Drosophila, the transgenic mice, and then the transgenic rats. And then we can go into humans. A long way to go. Yeah, I mean, I was talking more about the synapses is a target for our treatment, and of course then we also have to have biomarkers when we start the clinical trials or even on the animal data. And we find that EEG is a very good method where you have a lot of new software, so you can read a lot about the brain activity, the nerve cell activity, and the synaptic activity. And it's non-invasive, it's very cheap. Every clinic in the world has it, even in poor countries. And with modern software, we can see much more about the network. So if you have a synaptic stimulation, then I'm sure it will be a readout will be EEG changes. Then we don't need to take blood samples, we don't need to take cerebrospinal fluid taps, which is in some countries, like your country, England, is not done. Yeah, I think the implications are really that we will have new biomarkers. We have imaging biomarkers, MRI, functional MRI, positron emission tomography, and like us in Sweden, we do a lumbar puncture on every patient. But now we also feel that the development in the neurophysiology is very important for us. So we can read out a lot more, and we have also advanced EEG methods like the MEG, mesencephalograph, where we see much more. So we can really come deeper into the brain and we have a more sophisticated readout. Yeah, I mean that's of course a problem in the more advanced stages mainly, where we have to give our patients who have a lot of psychiatric and behavioral problems, aggressiveness, shouting, wandering, drugs, really. Of course, a good care is the optimal thing. But when that fails and you have tested all other possibilities, then we are still left with the neuroleptics. And the question then is, how should we dose it? What neuroleptics should we choose? How long time should we treat? And I think a recommendation is start slow, start low, and increase the dosage after time. And avoid side effects, because what is reported, you see an increased mortality if you go high in dosage and if you have the old traditional neuroleptics. Now we have more modern neuroleptics that seem to be a less toxic, but still, if you have to go up in dosage, they have the same side effects. I think you should test every reason for the patient's psychiatric or behavioral problems. And these persons in more advanced stages are really not good in communication. I mean, their language is deficient, their facial expression, their body language, the interaction between the staff and the patient is very problematic. So, of course, you have to have a good staff and relatives who understand what symptoms mean. But when you come to treatment, I would say start low and go slow.